members of medical fraternity. I, Suraj Tiwari from INTAS, welcome all to this webinar on germline and somatic defects and its impact on myeloid neoplasm. At the outset, I would like to quote that this continuum of this novel educational initiative is all possible because of Dr. M.B. Agarwal sir and MHG, and I'm thankful for this opportunity. About Dr. M.B. Agarwal sir, he's a renowned figure in hematology and he's an inspiration and for many, and his teachers of teacher, and he has been awarded the Inspiring Hematologist of India Award by Economic Times. We have Dr. Amit sir, Dr. Amit Khurana, who is a renowned hemato-oncologist from Surat. Sir is highly skilled and experienced hemato-oncologist with a decade of experience in the field, and he has extensive experience in both autologous and stem cell transplant. So, sir, over to you for further proceeding of the meeting, sir.
Thank you, Mr. Suraj Tiwari. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Talha Badr from Florida, and he's going to lecture us on germline and somatic defects in DDX41 and its impact on myeloid neoplasms. This webinar is brought to you by Mumbai Hematology Group, supported by INTAS and perfectly managed by Perfect Square. I thank Dr. Manoj Kumar and the team INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Talha Badr from Florida, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for spending the Saturday evening, morning and afternoon. Tomorrow, that is 19th of November 2023, Sunday, from 11:30 a.m. Indian Standard Time onwards, we have a webinar on reappraisal of the role of radiation therapy in lymphoma treatment by our guest speaker, Dr. Lina Speck from Denmark. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Professor Dr. A.K. Tripathi, Professor and Head Department of Clinical Hematology at King's George Medical University, Lucknow. Dr. Abhijit Giram from Saidri Hospital, Pune. Dr. Ami Patel from BCI Blood and Cancer Institute, Surat. Dr. Amrit Kaul Keller from Kokilaben Dhirubhai Ambani Hospital, Mumbai. Dr. Anand Kesi from Sri Shankara Cancer Hospital and Research Center, Bengaluru. Dr. Aniket Mohite from Jehangir Hospital, Pune. Dr. Arihan Jain from PGI Chandigarh. Dr. Avriti Baveja from Himalayan Institute of Medical Sciences, HIMS, Dehradun. Dr. Deep Gala from SGPJ, Lucknow. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. Karthik Kumar from AIIMS, Rishikesh. Dr. Karthik Purohit from Zydus Hospital, Vadodara. Dr. Kaushik Mandal from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Dr. Kripa Bajaj from Basavattarakam Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Manjit Mehta from KD Ambani Hospital, Andheri, Mumbai. Dr. Mona Vijayaran from Sahara Hospital, Lucknow. Dr. Omshri A. Shetty from Tata Memorial Hospital, Parel, Mumbai. Dr. Pulkit Rastogi from PGI Chandigarh. Dr. Rizwan Akhtar from SGPGI, Lucknow. Dr. Shruti Toshniwal Mantri from Shri VK Clinic, Aurangabad. Dr. Siddhesh Kalantri from Blood Care Hematology Clinic, Nashik. Dr. Stelin Chaudhary Bala from Nizam's Institute of Medical Sciences, Punjagutta, Hyderabad. Dr. Sudarshan Pandit from Ashoka Medicover Hospital, Nashik. And Dr. Vikas Talreja from Regency Hospital, Kanpur. Now it's the time to introduce our guest speaker for the day. We have with us Dr. Talha Badr from Florida. Dr. Talha Badr is Assistant Professor of Oncology at Division of Hematology and Medical Oncology at Mayo Clinic Cancer Center, NCI Designated Comprehensive Cancer Center, Florida. He's an Assistant Professor of Medicine working as a leukemia and myeloid disorder specialist at Mayo Clinic. His research interest is in acute leukemia and germline predisposition syndrome. His long-term goal is to understand mechanisms of clonal evolution of leukemia, developed innovative strategies to improve its clinical outcome. While treating patients with myeloid neoplasms, he developed very strong interest in patients with DDX41 mutation-related germline predisposition syndrome. As a PI and co-investigator, he also worked on research projects related to DDX41 mutation. Currently, conducting studies to explore functionality of DDX41 variants to determine pathogenicity and single-cell sequencing to discover unique genetic and epigenetic event associated with disease progression in DDX41 mutated patients. He is also actively involved in clinical trials in myeloid neoplasms at national and international level. And today, he is going to lecture us on germline and somatic mutations, defects in DDX41 and its impact on myeloid neoplasms. Well, thank you so much. Offer to you, Professor Talha Badr.
Thank you so much, Dr. Khurana, for a very nice introduction, and good evening. Thank you so much for the opportunity and invitation to discuss today about topic on DDX41 mutated germline syndrome. So we'll share my slides and is it look good to you guys?
Absolutely, sir.
Good. So let me check. Yeah, so this is the presentation outline. I will put forward a case presentation, a real scenario. Then we'll go over to the case presentation at the end of our discussion today. We'll briefly shed light on epidemiological data on DDX41 mutated germline participant syndrome. We'll discuss about clonal evolution of this germline participant syndrome. And then we'll talk about variant classification for this GPS, germline participant syndrome. And we'll discuss about the clinical phenotype, how these patients present, and what is the update on management of patients with myeloid neoplasm who had DDX41 mutation. And in the end, we'll summarize our discussion today. We'll go over the case presentation, and then I'll more than happy to answer any questions, concern if you have. So this is one of real patients who present in our clinic, a 75-year-old gentleman with no significant prior comorbidities on routine physical, found out to have pancytopenia. As you can see, hemoglobin 10.7, platelet 83, white cell count 3,000, variance of 1. He had done bone marrow biopsy for work of pancytopenia that revealed MDS with excess blast 2, and cytogenetics were normal. Interestingly, the genomic sequencing using 52 gene panel showed DDX41 mutation variant of M1I with 49% variant allele frequency, as well as EZH2 mutation with 7% variant allele frequency. We performed germline testing, and it confirmed DDX41 mutated germline participant syndrome. And then how do you treat this patient? So DDX41 mutated GPS associated with myeloid neoplasm, some of the salient features is it's most prevalent germline syndrome associated with myeloid neoplasm compared to other germline syndromes, around 2 to 5%. It's predominantly occur in male individuals, and it presents at advanced age in 60s and 70s, and interestingly, without significant familial clustering. And most of the time, we see these patients have a hypocellular bone marrow, hypoplastic marrow, and tends to run an indolent course, unlike de novo high-risk MDS and AML patients. Most of these patients have normal karyotype, and conventional prognostic factors really do not adequately stratify these patients. As you all know, we have now molecular incorporated prognostication system for MDS, as well as we have ELN updated 2022 criteria with more genomic incorporation in how we stratify these patients. However, in this particular scenario, as we're learning more, the standard risk prognostication system doesn't really do justice with this specific kind of myeloid neoplasm related to DDX41 mutation. So there's one study which is done in Europe using UK Biobank to study the prevalence of germline participant syndrome related to DDX41 mutation and how it presents in general population and what are the factors that lead to clonal evolution of this disease. Interestingly, what they found that it's one of the most common, as we have mentioned earlier, germline syndrome, and it's more common among those who have somatic DDX41 mutation. As you all know, the germline DDX41 have two alleles as other cancers, and one of them affected by the germline syndrome. And around 50% of these patients had another allele which is affected by somatic variant, and most commonly R525H. And what they found, those patients who had somatic DDX41 variants tends to progress more than other individuals, and patients who have IMCV. Most of our patients with high-risk myeloid neoplasm do present with macrocytic anemia, and what they found in this study. So there's another study in which they try to analyze the prevalence of all germline syndromes among patients who have hyperplastic bone marrow. And what they found, interestingly, around 6.7 patients carrying germline variants who present with hyperplastic bone marrow, and most common in order of frequency was DDX41, followed by Fanconi's anemia, followed by GATA2, haploinsufficiency, and other congenital syndromes. And as you can see from here, the mutation landscape, the most common variant among those patients who present with hyperplastic marrow or DDX41, followed by GATA2, alien, neurofibromatosis, and the rest. So now we have learned about the epidemiological data, as we learned that DDX41 is one of the most prevalent germline syndrome. Now we discuss about how this germline syndrome evolves with time. How is the nature of clonal evolution, how it makes it more interesting and intriguing compared to other germline syndromes. So somatic, so as you know, like all these germline syndrome is when they are linked to myeloid neoplasm, they tends to have evolution, and they supposedly should carry a somatic mutation that evolves the disease, as we see with high-risk MDS and AML patients. So there is a study done to study the evolution of DDX41-related germline syndrome, and they found out in the unmutated allele, the R525H is the most common secondary alteration. However, this is only seen in 50% of patients who transform to leukemia. And we've also learned that there is a small percentage of patients who do manifest age-related clonal at the time of transformation to high-risk myeloid neoplasm. Among those, most common, as you know, DNMT3A, AXL1, TAT2, P53. And what did they observe? The rates of age-related clonal in patients who had DDX41 and now develop high-risk MDS and AML is relatively lower than what we see in de novo MDS and AML. So this atypical pattern of evolution of DDX4-related germline syndrome suggests that this disease has a distinct entity, how it progressed, and we are still learning what are the factors that lead to this progression. Is it like a suppression of the immune surveillance, as we have reported, or is purely a somatic evolution, or there's some at the low level of these somatic mutations which are not detectable by conventional sequencing studies? So people have also studied the somatic mutation landscape of germline syndrome and DDX41 and compared to other germline syndrome and tried to study how this disease evolved with time. There are certain driver mutations that have been observed in all germline syndromes. And interestingly, as you can see, the most common three germline syndrome, DRUX1, GATA2, and DDX41, as you can see, the somatic mutation prevalence with VAF are significantly lower in DDX41 compared to other germline syndrome. That makes it unique in terms of how this germline syndrome behave when these patients progress to high-risk myeloid neoplasm. We did a study at Mayo Clinic using database of our germline clinic, and we found like 81 patients with germline syndrome, which are proven with some confirmatory tests to have a germline syndrome using our database. Among these 81 patients, we divide these patients into three groups to understand the somatic evolution, somatic mosaic states of DDX41 germline syndromes. There's one group of patients who have DDX41 mutation, and most of them have germline confirmation, but they don't manifest with myeloid neoplasm or precursor disease state. A second group of patients who have DDX41 germline syndrome, as well as have features to suggest clonal hematopoiesis independent potential or CCUS with no myeloid neoplasm. And the third group, which had advanced myeloid neoplasm at presentation. As you can see here, the prevalence of the somatic mutation, the most common somatic mutation as others have reported was the R525H at lower VAF frequency, around 55% of patients, followed by other age-related clonal like TAT2, DNT3A, AXL1, CBL, and KMT2CA. So consistent with the prior literature, it suggests that the clonal evolution in somatic mosaic states is significantly different compared to other germline syndrome when we talk about DDX41. So as you can see, only 55% of these patients had germline somatic DDX41 variant, and very small proportion of patients had other age-related clonal. So we need to further evaluate, understand the mechanism of leukemogenesis for this interesting DDX41 mutated germline syndrome. So as we stirred about the clonal evolution of this disease, that is unique, and we don't see a usual somatic evolution, unlike other MDS and AML patients. Now, a little bit discussion about the variant classification, how we classify these variants. So variant classification is challenging, and there is conflicting reports how you classify. As you all know, when we see a genomics data, we divide genomic variant into three categories: pathogenic, variant of undetermined significance, and benign variant. Variant of undetermined significance, or VUS, is determined since if we don't have enough data to support that variant causing pathogenicity. When we talk about DDX41 mutated germline syndrome, there's a conflicting data when you look at different genomic database like Genomat, ClinVar, and ACMG. So what we have, we did a study in which we compare the outcome and clinical phenotype of patients who have DDX41 pathogenic versus DDX4 VUSs. It's a pool of around 120 patients. As you can see here, different variants. On the top of this figure, the triangle are the VUSs, and the bottom with the circle represent the pathogenic variants. As I mentioned earlier, these were the most common variant which we observed in our study, R339H, glucine 247 glycine, and P255 leucine. These are the most common variant observed. As you can see here, as per ClinVar, these are all likely pathogenic variant because they behave as a pathogenic variant, whereas ACMG is still persisting and classifying these patients as VUSs. So there is some conflicting reports among the classification of this disease. However, there are some of these variants which are relevant in clinical perspective, and they do behave as a pathogenic variant. More needs to be learned how we classify these patients. You can see this Kaplan-Meier survival curves when we compare the survival outcome between DDX41 pathogenic and VUSs. As you can see in figure A, we haven't seen much difference in their survival outcome with comparable survival outcome compared to between pathogenic and DDX41 variants. So then about the clinical phenotype, how these patients present, how when these patients are DDX41 mutated germline syndrome, when they progress to MDS and AML, how these do present manifest. So unlike other germline syndrome presents with advanced age, and they don't have a familial clustering and mainly seen in have a male predominance. And they does not usually manifest a proliferative phenotype. We won't see a patient with AML having DDX41 variant presenting with high white cell count or serious disease presentation or related to the leukostasis. And they usually, when you do a bone marrow exam, you find these marrows are hypocellular, unlike hypercellular marrow, which you usually see in patients with high-risk MDS and AML. And anecdotally, we have observed some of these patients who are present with advanced age have stable counts for years, even presenting with acute myeloid leukemia. And they usually don't accompany with adverse risk mutations or cytopenic profile in general. So there is a study conducted in Europe in which they try to evaluate the difference in outcome among DDX41 GPS associated high-risk MDS, AML, and DDX41 wild type. Interestingly, what they observe is you can see here, the germline DDX41 mutated high-risk MDS and AML tends to have a significantly favorable outcome compared to other high-risk MDS and AML. So there is growing notion that DDX41 mutated germline syndrome tends to have a favorable outcome, and they compared to like other favorable AML and MDS patients. So now we know that these patients present advanced age, most of them an indolent course, and most have a favorable outcome. How you manage these patients, how it is different, how you manage them different to other conventional approaches we apply on patients with high-risk MDS and AML patients. So several groups, including ours, have reported the favorable outcome. However, there is no specific guidelines how to treat patients, probably since compared to other MDS and AML, that is not very frequent. And still, there are some centers in US around the world who doesn't have this DDX41 probe when they do sequencing studies, or they don't evaluate. We started doing detecting these DDX41 mutations maybe around 7-8 years ago or 10 years ago. It was not among the common genomic panel we do. And as you all know, the genomic sequencing is not globally applicable due to high cost associated with this testing. So there's limited information available about this disease, but what we know, it continues to have a favorable outcome in several retrospective and observational studies. And initial studies in patients with high-risk MDS shown that when you treat these patients with lenalidomide, it tends to have a better outcome. And we have also seen in our group that some of these patients with high-risk MDS with excess blast 2 with lenalidomide doing well for 4 or 5 years, which is very unique to this disease. Even in patients with high-risk MDS with 5q syndrome, the response rate to lenalidomide is around 40-60% and median time of response around 3 to 4 years. So they do really well. But what about AML? What about DDX41 mutated germline syndrome in occurrence in acute myeloid leukemia? So we don't know. So far, people treat, if they are young and eligible for intensive chemotherapy, these patients are treated with intensive chemotherapy like 3+7 or other high-dose cytarabine regimens. If they're older, now with approval of venetoclax, these patients are treated with Vidasa and venetoclax-based combination, or some patients may receive hypomethylation agent alone. So there are several reports reporting that venetoclax, a BCL2 inhibitor and a apoptotic, which has been a paradigm shift in management of elderly AML, have a significantly better response among patients with DDX41 mutated germline syndromes. We conducted a observational study in a series of 12 patients with high-risk MDS who received HMA plus venetoclax either for high-risk MDS, de novo AML, or relapsed refractory AML. And as we have seen earlier, most of these patients isolated DDX41 mutation without any concurrent somatic mutation. Interestingly, as you can see here, the overall response rate observed was around 100%, including patients with relapsed refractory AML who progressed for an HMA-based therapy for MDS, now a secondary AML, with the MRD negativity, with a very sensitive AML flow cytometry panel we have at Mayo Clinic. We found that these patients were MRD negative, and median overall survival, as you can see, around 29 months. So that's very interesting. And some others group from MD Anderson and at last year, EHA, they've reported a similar high response rate with venetoclax among patients with DDX41 mutated high-risk MDS and AML. So what is the role of allogeneic stem cell transplant? As we all know, for high-risk MDS AML patient, LO still holds a potential option to cure these patients. And it's been considered when we see patients with high-risk MDS and AML, and if they are eligible and have a donor available. Considering DDX41 tends to have a favorable outcome, how should we send all these patients to bone marrow transplant in first remission? Or should we treat them and observe them and consider transplant for relapsed disease? It's not known how to appropriately apply in a strategy and how to sequence what should be the treatment sequence or treatment algorithm when dealing with DDX41 mutated germline syndrome in patients with high-risk MDS and AML. It's a valid question because, as you all know, allogeneic stem cell transplant, wherever you do, it has a higher morbidity and mortality, 1 year mortality close to 20% in best of centers. So should we send these patients to bone marrow transplant in first remission, or should we continue with chemotherapy and some kind of a maintenance therapy and pursue transplant if the initial approaches doesn't work? So again, we used our DDX41 mutated database and to assess the benefit of transplant in improving overall survival. Interesting, although we have seen around 5 to 10% of these patients do present with co-mutation, high-risk mutation. If they present with an isolation with normal cytogenetics, may not be a bad idea to hold on and transplant, treat these patients with chemotherapy or some kind of a maintenance therapy. So as we learned that they tends to run an indolent course, and anecdotally we have seen some of our 80-year-old, 75 or maybe 85-year-old patients with this disease with some family history tends to have an indolent course, and I've observed them doing well without any treatment for 1.5 years and 2 years, and some of these patients have been observed for 3 years. So we did an observation study among 40 patients with this disease, and 68% of these patients received treatment for their disease with median time to treatment around a month, while 13 patients were observed and later on required treatment for disease progression. So none of the patients of the observation group died during the observation period, interesting to note. And what we observed that around 12 patients in the treatment group and 1 patient of the observation group died with a median follow-up of 43 months. The 5-year-old survival was 100% in the observation group and compared to 41 months in the treatment group. Again, it's a small sample size retrospective analysis, but something to consider in unique circumstances when the treatment may be challenging in patients who present with advanced age. So these patients can be closely followed up without affecting their long-term outcome as long as possible before pursuing treatment for these patients. So this is the summary, I would say, what we discussed today. We'll go over briefly. As you all know, this is the most prevalent germline syndrome in MDS and AML, main predominant without familial clustering. Most of these patients do have a high post-cellular bone marrow, and the clonal evolution of this disease is unique. Most common somatic variant we see is the DDX4 affecting the other allele. R525H variant is most common. 8-related clonal basis does occur, with is less than expected in other de novo MDS and AML. And treatment, well, the data, although we have seen that ven-based therapy does work well and some patients may be observed, but still, we need to learn more before we globally or universally apply what we observed in our observational studies. Venetoclax-based regimen tends to work better in this situation. Bone marrow transplant may not be a ideal option in first remission, as we do with other core favorable risk AML, right? Core binding factor leukemia, for example, we don't transplant them in first remission. We observe them, and if they do relapse, then we consider transplant to salvage and potentially cure them. And then the variant classification is challenging. Some of the VUSs as per CGME have a resemblance to more towards the DDX41 pathogenic. So we need to learn more about how we classify these patients. Among most common variants in the pathogenic group are M1I, D140 frameshift mutation, and among the most common VUSs are P258L, which is in some classification system are linked to pathogenic DDX41, and as well as M155I and others. With this, we'll go to our case. So what did the group think about how should we treat this patient? So if we at our center treated this patient with ven-based regimen, and he did well, achieved remission. He's 75, so borderline. So we are not pursuing transplant. This gentleman trying to continue some form of therapy and modified intermittent doses of HMA-ven and see how he does. With this, I would like to thank you all for listening, and any questions, comments are welcome.
Thank you, sir, for that wonderful talk. It was brilliant and superb. Very, very crystal clear. And now we have some Indian colleagues who are going to discuss you as a discussion. So, sir, are you ready with that?
Sure.
So I request all our discussons to please put the raise hand signs so that we can start our Q&A session with Dr. Talha. Badar? Yeah, Dr. Aryan Jain, your question, please.
Hello, sir. Sir, thank you for the talk. So, am I audible?
Yeah, you're
Yeah.
audible. Can you please stop your screen sharing so that we can visualize each other? Yeah, thank you, sir. Yes, Dr. Aryan, please go ahead.
Yeah. So, a couple of questions. So, one thing is that so a lot of these patients would probably be presenting as a hypoplastic MDS. So my question was that a lot of times the aplastic anemia patients or the so-called immune aplastic anemia patients are frequently confused with hypoplastic MDS, and even immunosuppressive therapy with ATG cyclosporin is kind of a valid option for hypoplastic MDS as well. So the first question is that if we look at the aplastic anemia cohort, what is the likely prevalence of this germline mutation, and what is the relation with the ENH clone size or maybe the class 1 HLA loss, which are kind of the retrospective markers of immune mediated damage, and would IST work in this setting, or we don't have data on this?
Yeah, interesting question. As you know, like what we have learned is MDS, aplastic anemia, and PNH tends to overlap with each other. And there is a study in which they study the hypoplastic bone marrow of patients and try to see the prevalence of germline syndrome. So as you can recall, like most prevalent germline syndrome or DDX41 followed by Fanconi's anemia. So whenever we see a hypoplastic marrow when thinking about therapy with aplastic in lines of aplastic anemia, we do check for like Fragile X syndrome and screening for Fanconi's anemia. In those situations, when these patients present at younger age, it's our practice to do germline testing of all these patients while we determine a treatment plan, how we treat these patients. Once you have a germline testing and when you rule out DDX41 related germline syndrome and you incline towards more aplastic anemia kind of a therapy, you can pursue. We don't have, to my best knowledge, we don't have any data about immunosuppressive therapy in these patients. With DDX41, we do have data on Revlimid, lenalidomide in patients with hypoplastic MDS with germline DDX41, and they tend to do better. But in general, the immunosuppressive therapy with ATG cyclosporin, I don't see enough data on that regard.
No. So my question is, if we have 100 aplastic anemia patients, no dysplasia on marrow, and if we happen to do a DDX41 germline testing in all of them, what is the likelihood that we would get these? Say, you told that in AML MDS cohort, the prevalence is, say, 3% or 4%. So what is the prevalence in aplastic anemia cohort? That's
7%,
what?
around 7%, and that observation rate around 7%, 6.7%.
Okay. And one more question, if I'm allowed to ask. Yeah. The other question is that, so you said that, so often the co-mutation is the somatic DDX41, which is happening. So if we look at the MDS patients or AML patients, are there any patients who are like only somatic DDX41 and no? So if we happen to do, say, paired sampling of genomic DNA and the blood DNA in a AML patient, so is there a possibility that, like RUNX1, sometimes we have acquired RUNX1 and we don't have a inherited one? So similarly, can DDX41 somatic mutation occur in isolation as well?
Yes, I have seen one case with somatic DDX41 without any germline variant. But intuitively, it's not common, but maybe our germline testing techniques need to be improved to identify these patients. So there's some lag in that behind, but I've seen a couple of patients in our database with somatic variant only without any germline variant. But intuitively, you won't see that happening. You would need to have this germline variant. And it shouldn't be occurring in isolation.
And one more question. So we talked about the that like relatively they are less likely to transform into AML. They have a relatively indolent sort of a course. But so in MDS, often the problem or the major cause of mortality is the cytopenias rather than AML transformation. So that's one of the. So how cytopenic are they? What is the transfusion burden with respect to packed RBCs and platelet requirement, and what is the usual degree of neutropenia and subsequent, say, risk of invasive fungal infections, etc., etc. So
Well,
median count.
No, I don't have data to support like what would be the burden, because these is less prevalent. But I would usually treat these patients as we do with other MDS patients, right? With supportive support like ESAs, minimizing tracernary possible. Maybe thrombopoietin analogs may benefit if they are thrombocytopenic and isolation low risk disease. As you all know, if these measures doesn't work, Revlimid is an option. If that doesn't work, then you can try ven-based therapies and so forth.
Thank you.
Thank you, Dr. Aryan. Dr. Fahima Hassan, your question, please.
Hello, Dr. Talha. It was such an elegant lecture. Thank you for that. 30 minutes, and it was so crisp that all our concepts were clear. I have some silly doubts as a doctor in India practicing. See, we always are not able to perform these NGS in our elderly AMLs, especially. So I do caught the fact that it's hypocellular normal karyotype macrocytic anemias patients and non-proliferative kind of AMLs that we are dealing when we come across as DDX41, right? So are we having any other morphology like in the Fab group kind of, like if it's a monocytic kind of AML or anything of that cues or an immunophenotypic cues which we can use as an alternate marker to identify such, because these are the patients whom I will be counseling for therapy. Most of the time, if it's a patient around 70, 75 years, they choose to go for best supportive care. The families, especially counsel them for additional genetic testing. Are there any soft markers that will, really make us push the patient to go for genetic testing? Is my first question. And the second question, yes, I saw, 100% OS.
Dr. Fahima, your voice is breaking. We could not hear you.
AZA or decitabine is beautiful. Am I not audible, sir?
Can you please repeat the question once again? Because it was...
Hello?
Yes.
The
first question was on morphology, right? Is the morphology which can guide us if it is more related? It's a very interesting question, and we're trying to ask our hemopath people to look at our database and see if one morphological subtype is more prevalent than the other. I don't have an answer for that at this point in time, but I would use other parameters. If someone advanced age, with maybe like if you do like a thorough history, if you see like a familial history of individuals with brother or first cousins or someone in the family with heme malignancies and the present hypocellular bone marrow doesn't have a very, so I would use those markers to identify patients and encourage them to have a germline testing. It's a very valid question, very clinically applicable. So again, for good history taking and try to figure out other ways in which we can narrow down and be cost effective in terms of whom we refer to germline testing and whom we refer to genomic sequencing and look for DDX41 mutation. At this point in time, I don't see we have a lot of data to support that there's one morphological subtype more prevalent in this group of patients.
Yeah, the other question, sir, is if this is an AML DDX41 mutated, what is the role of HMA alone without added venetoclax? Or what was the least dose of venetoclax which you tried in these patients because of the risk of infections, especially in a tropical country like us, which the patient can tolerate? So
yeah, no, very interesting question. I think after the lenalidomide data, there is some data in which people from Asia, there is a paper from Monokshima, like in blood, in which they find the HMA also works better in this group of patients. And there is some data when based. So what I would say And there is some data, if you look in context, like 7+7 presented last year ASH, in which they used 7 days of white data and 7
Yes.
and it
15
tends to,
then.
that could be an option. And what I have seen here in personally, even like in 75 and 80-year-old, they may tolerate 14 or days or 3 weeks of when, but subsequent cycles I had to cut back to 7 days and 5 days and 10 days, and they do maintain remission for a long period of time. So you can modify the dose of venetoclax to minimum up to 7 days, what I've done, and some of my patients without not the DDX41 in general, AML patients tends to maintain if you continue some kind of maintenance therapy rather than delaying treatment for 8 weeks for count recovery. If you maintain some kind of therapy of supportive care, maybe Neoplasms in between, it tends to maintain remission. So I would say gradually, depending on the response, you can cut down the dose of venetoclax for better tolerability.
Any other question, Dr.
Thank you. Thank you so much, sir. Thank you.
Thank you, Dr. Prima. Dr. Pulkit, your question, please.
Yeah. Hi, sir. So very informative session. So I have just
Thank you, sir.
I have just two quick questions. The first one is how you deal with the situation where you have conflicting database interpretations, like you have shown two cases where the ClinVar was revealing likely pathogenic and the ACMG as VUS, because we do face sometimes we report as VUS and sometimes it becomes the likely pathogenic. So you take the upper one, the likely pathogenic, or how you go about? And the second question is what strategy you follow for the germline testing, what tissue you take and how you proceed.
Yeah, thank you. So the discussion about the conflicting reports and VUS and pathogenic, it's mainly focused on DDX41. I don't have the data to support if we can apply this to other somatic variants, right? So we are just focusing on DDX41 right now because the protein curation and interrogation is challenging in this subgroup of patients, which we haven't seen with other somatic mutations. So for this particular DDX41 mutation, as we have discussed earlier, if the other issues, like these patients have some family history, advanced age, indolent scores, hypoplastic marrow, and strong history, appealing history that these patients behaving different to our usual de novo MDS AML patients, you might consider. And then there are certain variants, not all of them, like there are various VUS variants, around 5-6 of them, which I've seen with conflicting reports, and they behave similarly. So if you find those variant, although the classification is challenging, but I will treat in the lines of DDX41 mutated GPS with MDS and AML. Routinely, what we do here in Mayo Rochester, we do like a hair follicle testing. It is not validated as a germline testing universally, globally. Most of the people will do a skin fibroblast culturing. That's easier to validation, and that is most commonly people use. But we did set up a certified program which we do a hair follicle testing, but usually commonly we do a skin fibroblast culturing.
Thank you. It was informative.
Thank you, Dr. Pulkit. Dr. Avriti Babaji, your question, please.
So first of all, thank you so much for this wonderful talk. So how common is to get myelofibrosis associated with this mutation? And sir, what remains your approach to manage such cases?
Yeah, that's a very good question. When I last searched database, there were like 3 patients myelofibrosis with DDX41 mutation. So out of a sample of around 130, 140, I have the 3 patient myelofibrosis. So there is not much data to support how differently I would treat these patients. I would explain data from our myelofibrosis guidelines and other guidelines to manage these patients with limited data to support or to see any difference what we observe in MDS and AML specifically. I've seen it in MPN, but very, very infrequent.
Thank you, sir.
Thank you, Dr. Avriti. Dr. Amrit Keller, your question, please.
Good evening. Thank you so much for the insight on DDX41 variants and the mutations. So my question here is, I read an article in which they said the DDX41 VUS behaves similar to DDX41 pathogenic mutation, in terms of clinical outcomes and also the history. So my question is, should we start considering VUSs also if we get it on a NGS testing as pathogenic?
Yeah, I would say in context of DDX41, if you have a VUS with high VAF, let's say 50%, and if these VUSs, the most common ones, which are in ClinVar, likely present, in general VUSs, if you have a classical presentation of DDX41 mutated germline syndrome like hypoplastic marrow, advanced age, maybe some family history, and you find the VUSs and in isolation without any occurrence of high-risk somatic mutations, I would treat like a DDX41 mutated germline syndrome.
Thank you so much. Thank you.
I would prefer doing a germline testing in those situations also.
Also, yes. Thank you.
Thank you, Dr. Amrit Killer. So we have some few questions from the audience. Dr. Krishna Ratnam Kannan wants to know that how do you choose a donor for allo stem cell transplant with DDX mutation? That is the first question. And second question is, does the family donor needs to be tested for DDX mutation? If so.
Wonderful question. Like I will not prefer match-related donor. If we come to in a situation where we need to transplant these patients, we shouldn't be considered. And anyone you see in your clinic and you prove them as germline variant, strongly encouraged to counsel the family to get them tested and observe them longitudinally to see if they progress and develop myeloid neoplasm. And definitely we won't be choosing a even if you do the screening, I'll be hesitant to use a family donor for transplant.
Thank you, sir. Another question from Dr. Ramamurthy. Will you use a young DDX41 carrier son as a donor for DDX41 germline and somatic mutated 70 years old male with AML? He has a very bad risk genomic profile and he requires a transplant.
No, I won't choose a family member. I will use for unrelated donor if we can get but I won't use, I will hesitate to use a family member because although they are asymptomatic carriers, we have seen, although the trajectory may be slow, but down the road, these patients may evolve to a myeloid neoplasm.
Thank you, sir. So that's it. I finished the questions from the audience. And any discussions wants to ask any question to Dr. Talha Badar? Yes, Dr. Arianjan, please go ahead.
So, sir, considering it being a familial kind of a thing, are there any clues regarding the ethnic groups? So is it, so we talked about the male predominant part. So, so Africans, Caucasians, or Asians. So is there any suggestion on any particular ethnicity or ethnicity predisposition for this?
Yeah, that's a great question. That's a great question. We in US have seen most common in Caucasian, but there are certain variants. There's a recent blood paper with the Japanese group, which are more predominant in Asia, and there are some variants which are more predominant in US or European population. So there is some disparity in terms of variant. But what we have seen here is, like in US, 80%, 70-80% population is Caucasian. So we usually seen in Caucasian population compared to Hispanics and African Americans. But there is some differences in the variants we observed here compared to what we've seen in Asia.
Thank you, sir.
Thank you, Dr. Arianjan. Any other discussions wants to ask any other question? Because there are no more questions from the audience. So, well, sir, there are no more raising signs. Thank you so much for that wonderful and fantastic lecture. You were superb, very, very crystal clear lecture. And really, it was great learning from you. And I thank all our discussants over here to present over here this Saturday evening. And thank you, sir, for being with us early morning for you today. And I also thank all our audience to be present over here and participate in this webinar. Thank you, sir, once again for joining here. It was very pleasure to have you on board. It was a great learning from you, sir. Thank you so much. See you tomorrow, exactly at 11:30. Yes,
thank
sir.
you so much for being me here. It's my pleasure, and to discuss a wonderful discussion, and happy to participate in these forums and academic activities. Thank you so much.
Thank you so much once again, sir. It was a great discussion, wonderful lecture, fantastic, super and fabulous lecture. Very crystal clear, sir. Thank you so much.
Thank you. Thank you. I wish you a very good weekend and best of luck for the final tomorrow.
Thank you, sir. Thank you so much.
Thank you, everybody. Thank you.
Thank you all the discussants and audience joining over here. Meet you tomorrow at sharp 11:30 a.m. for another beautiful webinar. Thank you so much. Bye.
Thank you.